Good morning, everyone. Thank you so much for joining us today. Right now, we are sharing a screen on how to claim your CME/CE credit. These steps must be done within 30 days of the event, and we will reshare this information in the chat. So first step is to go to med.cmich.edu/CME/CE credit. And you'll have to sign in or create an account. Then you'll click to claim credit, and then that is on the left banner. And then click claim credit for other and select the session you attended. We will also be emailing out your certificates for your SUD credit. So thank you so much for coming and attending today. And I would like to now introduce our speaker. Our speaker today is Monica Walker. Monica earned a Bachelor's of Art in Psychology from the University of Michigan and a BS in Nursing from Wayne State University and a Master's in Administration with a healthcare concentration from Central Michigan University. Her work experience has been predominantly in emergency and peri-anesthesia nursing, with several years in nurse management prior to joining Michigan Medicine. In blending her work experience and education background, Monica provides the bridge between Michigan Open's initiatives and collaborative partnerships. I hope that you enjoy today, and Monica, take it away.
Thank you, Elise, for that introduction. And I guess I can say fire up chips, having been a graduate from their master's program. Can everybody see my screen? Thank you very much for this opportunity to present today on a very important topic, stigma, and more importantly, on how to move beyond stigma. My goal today is that after this presentation, you can speak to the following three objectives: that you'll be able to understand opioid use disorder and importantly, what it is and what it is not. You'll be able to describe how stigma negatively impacts recovery, and you'll be able to list some behaviors that can promote compassionate care in moving beyond stigma. You've heard from several speakers within this series, but as a recap and to somewhat frame our conversation around stigma today, I'd like to share with you that 130 people die each day from an opioid-related overdose. And to put that number into perspective, that would be about one Boeing jetliner going down each day. And that additionally, there's 2.1 million people that have been diagnosed with an opioid use disorder. And of course, unfortunately, we can't discuss the opioid epidemic without touching upon COVID-19's impact. In Michigan, fatal overdoses were 15% higher during the pandemic than the same period of time in 2019, before the pandemic. And while this presentation won't delve into all the issues that potentially drove that increase, notably our current state makes our continued work in this space so very important. I wanted to share a bit of background on Michigan Open and our work in relation to this stigma presentation. For those that attended on Monday, Dr. Chad Brummett's presentation, some of this information is a recap. So the Michigan Opioid Prescribing Engagement Network, or Michigan Open, was established in 2016 with a focus on evidence-based prevention within acute care episodes, that being surgery, emergency, and dentistry. When we started, as Dr. Brummett pointed out, the focus truly was on treatment, which is very important. However, what we were not doing was kind of looking behind us and seeing that the door was wide open. So Michigan Open sought to find evidence-based solutions to how to close that door and keep patients from starting down the path of opioid misuse and addiction. The evidence found that across all types of surgeries, which are listed here, several of them, approximately 5 to 10% of patients who had not previously been exposed to opioids prior to surgery would develop new persistent opioid use, meaning that those patients will continue to use opioids long past the expected course and the resolution of their surgical pain. Oftentimes surgery and even dentistry, especially for youth, is really the first exposure to an opioid. So this new persistent opioid use truly is an avoidable surgical complication. And just to point out, the very last bar that shows breast cancer at 19%, that is somewhat higher just because that usually involves a lot more surgeries and more opioid use. But again, just roughly between 5 to 10% are going to develop new persistent opioid use. So visualized in a bit of a different way, of those seeking surgery, 8% will chronically use opioids before surgery, and approximately 30% intermittently use opioids. And of the remaining patients, those that have not been exposed to opioids prior to surgery, that 6 to 10%, will develop that new persistent opioid use. To that end, it should be considered best practice in any care setting, truly, to complete a risk assessment or screening on all patients, as this is really an opportunity to manage risk with early care coordination. So some examples of our work in screening can be seen in our Transitions of Care project. Transitions of Care is the coordination of that care that should occur when a patient moves from one care setting to another. So in our case, we recently completed phase 1 of our pilot where we screened surgical patients preoperatively to identify those that may require more support due to recent opioid exposure to achieve the best surgical and pain management outcomes. And we also have an ongoing project in select emergency departments throughout Michigan, which will be moving towards screening for opioid use disorder in their emergency department patients. So while the benefits of risk screening are clear, or very clear, in practice, the stigma associated with opioid use disorder can present a challenge to fully embracing and implementing this practice. And there's where those initiatives really come into play and intersect with the stigma that I'm talking about today. So an important step in overcoming stigma is education. We need to educate our communities and our healthcare personnel on what OUD is and it is not, which is critical to normalizing screening, which again aids in that early identification of people that would benefit from care coordination and intervention. So what's the science behind OUD? As early as the 1950s, I was surprised to find, OUD was being discussed already as a brain disorder. And then in the 1990s, scientists using brain scans were able to show actual physical changes in the brains of those with an OUD. So specifically, the two areas of the brain that are impacted are the limbic system, which is responsible for basic survival instincts such as seeking food, water, shelter, and the prefrontal cortex, where decision-making and impulse controls happen. So with repeated opioid use, these areas are essentially taken over, and those basic survival instincts in that limbic system now only focus on seeking opioids, and the cortex's decision-making and impulse controls no longer have the capability to stop the negative behaviors associated with this disorder. The National Institute on Drug Abuse defines addiction as compulsive drug use that continues regardless of negative consequences, meaning that that person who loses their job, their health, their family, due to their addiction continues their drug use because their brain has changed. This is not a moral failing or a lack of willpower, but rather genetics, along with environmental factors such as their first introduction to an opioid, which I mentioned earlier, a lot of times for youth is in dentistry, impacts the risk of developing opioid use disorder. But it is important to know that opioid use disorder is a chronic treatable brain disorder. So the DSM-5 is a manual for assessment and diagnosis of mental disorders, and it lists the 12 symptoms of OUD. So in order to actually be diagnosed with this disorder, you have to show at least 2 of the 11 symptoms. And these behaviors are truly the manifestation of the disorder. And the behaviors are the symptoms. And that's really important to understand because whereas with other medical illnesses where there are physiological changes or with a disease, in this case, the changes are there in the brain, but what the public sees and your colleagues and your family are the symptoms, which are these behaviors. And the more symptoms, the greater the severity of the disorder. These individuals truly deserve the same level of care and treatment as anyone suffering from a medical condition. And the notion that someone needs to hit rock bottom before being offered treatment really is not evidence-based. If you think about it in comparison to a medical condition, would we ever wait for end-stage kidney disease before offering medical intervention, or wait until the cancer has progressed to stage 4 before suggesting chemo? And I think that really puts it into perspective. So by definition, stigma is the perception that a certain attribute makes a person unacceptably different from others, which leads to prejudice and discrimination against them. Stigma is a barrier to diagnosing, treating, and maintaining recovery from opioid use disorder. And it can impact resource allocations, reduce the likelihood to screen and address any substance use disorders, and ultimately keeps individuals from seeking treatment. We can't look the other way as a society. This disorder is non-discriminatory. It crosses all socioeconomic statuses, all races, all genders. And those that are suffering are your neighbors, your children's friends, or your children, or your acquaintances, and maybe other family members. Yet stigma can keep those we know and love from recovery. Our past US Surgeon General spoke about stigma and how it keeps people, quote, in the shadows, which results in not seeking help. And I would also propose that not only does stigma impede recovery, but it also silences those that have recovered from speaking out and sharing their stories so that others can hear and have hope. Yet there are treatment options. These can be categorized into abstinence-based or non-medication-based programs and can be either religious or secular, and programs using FDA-approved medications that normalize the brain chemistry. These medications are commonly referred to as MAT or MOUD. And because we're talking about stigma, I think this is an important point that I've learned along the way. So the difference between MAT versus MOUD really is pretty much the same, and they're used interchangeably. But MAT is medication-assisted treatment, and it's described by SAMHSA, which is the Substance Abuse and Mental Health Services Administration, as the use of FDA-approved medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of any substance use disorder. Some actually also say MAT stands for medication for addiction treatment. MOUD, however, on the other hand, truly is the preferred term, meaning medication for opioid use disorder. And in using the acronym MOUD, it emphasizes that medications should be the treatment priority, as they have been found in multiple studies to be effective. While the evidence has shown that the use of MOUD decreases the likelihood of dying by up to 50%, sadly, only 1 out of 10 individuals with this disorder will receive these evidence-based medications for treatment. This underutilization of MOUD may be due in part to provider comfort level or provider biases, in addition to patient and family biases. It's important to debunk the myths around MOUD. These FDA-approved medications are not the trading of one addiction for another, like some may believe, but rather truly allowing the individual to control the opioid craving so that behavioral therapy can be implemented in conjunction with the medication. If your only focus, when you're thinking back of those basic instincts of survival, and for an individual with OUD, thinking that their basic survival is around seeking an opioid, you need to normalize those cravings. So then they are open to the behavioral therapy that can come next. MOUD does not produce a high and has a significantly lower rate of diversion in comparison to opioids. And most importantly, these medications allow a patient to have a functional life. I want to share with you a few slides developed by Dr. Gina Dahlem. She's a nurse practitioner and faculty at the University of Michigan School of Nursing, who is also leading our emergency department initiative that I mentioned earlier. These are actual quotes from conversations that Dr. Dahlem had with peer recovery coaches, with people in recovery, her own personal experience as a provider, and even with providers who have loved ones in recovery. And reflecting back on my own past career as a former nurse in an emergency department many, many years ago, it really saddens me to say, but I can attest to similar thoughts, both from myself and my colleagues, not recognizing them at the time as stigmatizing biases and lack of education in respect to OUD. But I would present to you that if the patient has a different perspective, so this individual suffering from opioid use disorder, they have their own underlying feelings of hopelessness, failure, worthlessness. So if you were a provider, how would you respond differently if you knew these were your patient's thoughts? What if you were their neighbor or their friend? We need to be aware of our own biases so that we can develop more patient-centered language and approaches to our care of these individuals. Developing patient-centered or patient-first language is so important because words matter. Recognizing that this may be easier said than done, we just need to keep self-correcting and striving to get the words right. If we as healthcare professionals start using non-stigmatizing language, then our patients will use the same non-stigmatizing language about themselves, which will then help them recognize that they have a disorder, which can then lead them to seek treatment. And if we use non-stigmatizing language in front of our nursing or medical students, or even our family and friends, then they too will begin using non-stigmatizing language and have a better understanding of how this is a true disorder. The right words will definitely impact the care that we deliver. If empathy is seeing with the eyes, listening with the ears, and feeling with the heart of another, and compassion is sensitivity to the suffering of self and others with a commitment to relieve that suffering, then perhaps compassion might be viewed as empathy translated into action, which is what draws healthcare professionals to their profession. And receiving empathetic care can spur recovery. Through these past few days, we heard great presentations on stigma's impact on subpopulations. On Wednesday, we learned that 5 to 10% of pregnancies involve a woman with an OUD. Dr. Nancy Renbuge spoke about pregnant women and their fear of admitting to drug use or seeking treatment for fear of having their baby taken away, the shame that they experience due to stigma from society and potentially even their healthcare providers, thinking they are willfully putting their desire for opioids ahead of their baby's welfare. And the misconception that neonatal abstinence syndrome means the baby is born addicted, when in fact babies are not born addicted, but rather are withdrawing, and it's an important distinction. Nancy informed us that while opioid use in pregnancy has increased, this could be a pivotal point in the woman's life for intervention and treatment, yet stigma presents a barrier to receiving that treatment. And yesterday we heard from Judge Patrick Shannon on the tribal courts and their comprehensive, unique approach, even having a physician and a nurse practitioner involved in the court proceedings, which is a true testament to opioid use disorder as just that, a disorder. Recently, I also had the privilege to hear a young man's story of incarceration as a result of his OUD behaviors. These individuals, the incarcerated subpopulation, also experience fear and shame around their drug use, and upon incarceration, there's likely little or no treatment available. Often of the 3 FDA-approved medications, there may only be one option. And I've heard it said that connection and employment is an important component to long-term recovery. Yet this subpopulation, upon re-entry into society, may find little support for their disorder, compounded by their criminal record, which now presents a barrier to both connections and employment. And additionally, as Patrick touched upon yesterday, leaving the prison system creates a critical situation in which if they go back to using, it's likely going to be at the same amount prior to incarceration, yet that forced abstinence while they were incarcerated and then using the same amount could result in a fatal overdose. I've also included as a subpopulation those patients or individuals that suffer from chronic pain. because I believe they too experience stigma. The vast majority of individuals taking opioids for chronic pain take them as directed and do not have an opioid use disorder. Yet many who likely are uneducated about opioid use disorder may not make this critical distinction, even in the healthcare system. In the pilot study, which I mentioned at the beginning that Michigan Open recently concluded, we came across a few patients who actually screened for being on low dose buprenorphine, but it was for chronic pain. And those patients, when we were speaking with them, actually expressed frustration that their healthcare providers assumed they had an opioid use disorder since they were on the buprenorphine. And these patients too felt stigmatized. I'd also like to touch upon those that are grieving. Those individuals who've lost a loved one to a fatal overdose also experience stigma, which exponentially increases their grief. A little story that has stayed with me for years. I volunteer in a community coalition in my county, and early on I met a woman whose story really impacted me. This woman's teenage daughter died from an opioid overdose. She was found alone, dead in her car, in a parking lot by the police in late night. That alone, just to know that that's where your child passed away as a parent, was beyond measure. But then her grief was, again, really expounded upon by the fact that the story she gave was that her and her husband were seeking support. So on the way to a support group for parents who had lost a child, her and her husband were actually discussing what story they would tell for how their daughter had died. And to me, it was just so hard to comprehend that in the midst of their grief, these poor parents didn't feel they could share their reality because of stigma, that others in the group may not understand their grief, may not equate their loss to the loss of a child from a more acceptable cause, such maybe as a car accident or cancer, could potentially judge them as parents or even think ill of their deceased child. Stigma, again, impacting someone who needed support and compassion. Stigma silences not only those who would otherwise seek treatment, but potentially those in recovery, especially those individuals managing their disorder with MOUD. These individuals may feel the need to hide their treatment from their friends, family, and colleagues for fear of stigma or pressure to manage their disorder without their medications. Importantly, any treatment option will likely require repeated attempts at recovery. By the very nature of the disorder, relapse is likely. And while this is disheartening, it is not a failure. This is an opportunity to evaluate what prompted the relapse and to continue to seek treatment. Again, there are various different treatment types that we spoke of earlier. And I've heard Dr. Kara Paulin speak before on this, and where she advises her patients that potentially they may need to try 5 to 6 different groups, maybe the same type of treatment, but maybe a different group, if it's a support group, in order to really find where you fit. Importantly, also, Dr. Allison Lin, an addiction psychiatrist at the University of Michigan, stated that patients with OUD, by definition, have a hard time stopping, and their desire to enter treatment will likely waver. And Dr. John Kelly, an addiction psychiatrist at Harvard Medical School, found that on average, for any substance use disorder, it can take 4 to 5 treatment episodes, again, on average, to achieve 1 year of sustained remission. So as we learn the facts and educate ourselves about opioid use disorder, it's important that we remember this so that we continue to give compassionate care and we continue to provide treatment options. Opioid use disorder is treatable, as evidenced by the number of individuals in recovery. 25 million are currently in stable remission, meaning 1 year or longer. That's a pretty impressive number. And sharing stories of recovery can truly spur treatment. even or especially those stories of multiple attempts at treatment before achieving long-term recovery. Because what works for one person may not work for another, but it's important that we don't give up and that they do not give up. And so sharing these stories of recovery, these 25 million stories, will help tear down the wall of stigma and can help others. So we can be that change, and we can help move beyond stigma through education, understanding opioid use disorder and its evidence-based treatment, understanding and recognizing stigma and how it impacts recovery, through recognizing and working through our own unconscious biases, especially for those in healthcare who are viewed as role models. And lastly, by doing the hard work to use person-first language at all times. Michigan Open is excited to be partnering with Shatterproof, a national nonprofit, in work around stigma. I would encourage you to save the date of June 10th for a symposium, which we know will be informative and engaging. In closing, I've included these additional resources, which I found particularly interesting if you wanted to look into them a little bit further. Michigan Open's mission is to change the way we manage pain, which is possible by meeting stigma head-on. Together, I believe we can all make a difference. And to learn more about our work, please visit www.michigan-open.org. Thank you very much.
One thing that stood out from your presentation, I'll just start, is that story of the parents and how they had to come up with a narrative to talk about their child's death. And a lot of times, we don't really think about that. So that is very insightful for me. Could you just share ways that you would encourage parents who may have lost a child to a substance use overdose on how to share that with support systems and groups?
That's a difficult one, because while their experience was very sad, I don't know how they can do that without feeling comfortable that others in the group would really understand the disorder. So if you're in a group that perhaps would allow you maybe to speak to the disorder as a disorder, so that you're educating your peers that are in this support group, I think that would be a good place to start. Maybe going to the person who's leading it and saying, just being really transparent. My child died from an overdose. I want to share, but I feel like others may not understand it. Would it be possible to just share a little bit about what opioid use disorder really is? Because I hope that the one thing that the attendees take away from this presentation is that education really is the tool. And Judge Shannon also mentioned that we need to educate, because until we recognize that there's physical changes in the brain, that this is not like willpower or lack of willpower, that these behaviors are the symptoms, and that going in and out of treatment until they find something that ultimately ends up providing their recovery for them is all part of the disorder. And as a former bedside nurse or actively nursing, I just think it begins with the healthcare providers, because they are the role models. And whether we're at the hospital or in our homes, we need to catch stigmatizing language and really address it.
Thank you for that. And we have a question. It's what specific things can we do in our communities, schools, etc., to open up this sensitive conversation about SUD, OUD?
Again, providing education and truly normalizing it. Like, I believe that the great majority of people know there's an opioid epidemic, but they're not understanding OUD as a disorder. And even in our project or in our pilot where we were screening patients, after the screening, we had a couple of questions for the patients that were screened, and one of them was, did you feel comfortable with these questions? Did you feel that they were asked appropriately? And it was interesting. I would say 99% felt they were asked appropriately and that they felt comfortable answering them. But then we would get those little anecdotal responses from people that would say, I'm in healthcare myself, and I'm thanking you for screening, because this is how the conversation gets started. And if patients can start hearing this conversation in their primary care physician's office, and then when they go to surgery, prior to surgery, and maybe when they go to the ER. And that's why I stated that it's so important that we screen in all aspects of care, because then it normalizes that conversation. And then, because some people tend to think, well, why are you asking me? Are you targeting me? Do I look like somebody who, and that's all part of that stigmatization. But if this just becomes part of our normal language, then it's not so stigmatizing, and then people will be more open to discussing it.
So as someone, I know that I work in public health, where, you just talked about stigma and education. What is the best place to start with that conversation of changing the stigma around STD OUD?
So Shatterproof is a great organization that we're starting to do some work with, and they have a lot of really great initiatives, and they truly are the experts. So I would highly recommend that if you can, to attend the June 10th, I think it was, summit, because they have a lot of information and conversation around the work that they have done, because this is a huge, huge focus of theirs. That being said, I think anytime you're trying to implement a change, and education is a change, I would say that it has to be multifaceted and an attack, for lack of a better word, on all fronts. So begin with the children in high school, when we have those conversations around drug use, whether it's alcohol or opioids or stimulants that we're seeing more and more of, to talk to them there, to talk in public safety announcements, to bring education to healthcare, to within your community coalitions. I just think it's important that everybody truly understand this disorder, because unfortunately, and with the pandemic making it worse, it hasn't gone away. And so education really is the tool, and education may look different in every type of setting.
Yes, you are right there. I know at the end of your presentation, there's a question. You mentioned some resources. Someone would like to know, how are they able to access those resources that you mentioned? So more information on that June 10th event.
Sure. So if you go to michigan-open.org, we have it on our website. We have the seminar. We have a newsletter that goes out. If you would like to reach out to us and be put on our newsletter, as well as the resources. I think it was the second to last slide. I put in some QR codes, as well as the URLs for 3 different videos that I thought were really good. A Dr. Carolyn Greer, who's an addiction specialist. There's one on Brene Brown, who talks about empathy, which is a short little clip, and it's very powerful. And then another one on the science behind opioid use disorder. And I believe these slides will all be sent out, correct?
I will check with the team, but
I thought that was my understanding, is that they will be sent out to the attendees altogether. So hopefully you'll be able to get those. If not, come to michigan-open.org.
Hi, this is Gail. Yes, all the slides and the recordings of the lectures this week will be sent out, and they will be available on our website in early June. So.
And actually, I believe CMREN also has, in their own newsletter, has advertised the June 10th summit.
I believe so. It was in our newsletter. And then someone put in the chat the information about the June 10th event as well.
Yes, that's my director. Thank you, Beth.
There's another question. It's, where can we go to find continual education on stigma?
Unfortunately, I don't know the answer to that, but I would actually say to go to Shatterproof. Shatterproof.org, I think, is their, let me see.
Additionally, in regards to the continuing education credits for substance use disorder specifically, we will be sending out all certificates after the conclusion of this event.
And somebody put in Shatterproof's URL in the chat box. I would go there if you're looking for CE specific to stigma. I would go there first. Thank you, Kate.
So at this time, no more questions. Thank you for attending, and thank you, Monica, for your wonderful presentation. And have a great week and weekend.
Thank you very much.